things I love to do when I teach OTAP or anything with patient assessment, and for you, really, this is kind of a refresher because you went to EMT school and you went through all this stuff in EMT school. Now we're doing it again. So let's look at, I'm going to erase this. I don't have a lot of blackboard space, so I'll use this one. I guess I can use the one right there, too. Yeah, I'll use that one back there. So we've talked a little bit about, in the last segment, about pulse and respiratory count, and I know we know about blood pressure. So we know that you take a blood pressure. I don't know all there is about blood pressure. And when we take pulse, the three things that in respirations, rate, rhythm, and quality, and then blood pressure. What are some other, I guess we can call them vital signs, we can call them assessment tools, we can call them diagnostics. That makes it sound like we're working on a car. But what are some other things that we use to assess a patient? We had skin we talked about. I'm going to steal Sean Pitts's what's the CCT? That's color. Skin. Sean always says CCT. Temperature, color, and maybe temperature. Yeah. Yeah. So we can assess skin. What are some other tools we use out there to assess a patient? We did mention lung sound, so I'll throw that up there too. Visual. Okay, so their appearance. Pulse ox. Pulse ox. Now we're talking. Okay. Okay. Slow down here a little bit. Pulse ox. What's pulse ox measuring? Say that out loud, so everyone can hear.
It's the percentage of saturated hemoglobin compared to non-saturated.
Okay. The reason I wanted to say that out loud is if that comes up on a test question, that might be the way you remember it.
Oh, it was a test question.
It was a test question. Okay, so someone else threw out some of the, I heard glucose. Okay. What's our normal range? 80 to 120. Okay. And we measure it with the little finger stick, correct? What's your little machine going to tell you? What's high mean on your machine? Over what? 500. Over 500, or maybe 600. Depends on the equipment. And what else can we assess? So we got glucose. We got pulse ox.
GCS.
GCS. Okay. Tough one to remember, but we can do a GCS. What else? What's that? Ooh, my favorite. I heard that. So capnography, normal is for any age, right? And what's it mean in general terms? I want acid, base, this kind of stuff. If it's low, capnography is low. Tell me what comes to your mind. Low capnography reading. What's that? Hyperventilating is one. Put this one away in the back of your mind. Low perfusion. Or poor perfusion. Think of that. Poor perfusion. Low capnography, poor perfusion. Low capnography, poor perfusion. So we have capnography of 20. Glucose reads high. Sick patient, right? Sick patient. Glucose reads 20. We'll keep that at 20. What's that tell you?
Anxiety.
Sick patient. Maybe anxiety, but let me throw in this. A little bit of history. Okay, yeah. All right, so we went from anxiety to sepsis based on this, right? So what's the moral of that story? We got to get a full assessment. We got to get a full patient history. We got to do all this. Anything else on here? What's that? Okay, pupils, sure.
Looking at your partner's face.
Okay, you have to have that pupils. When we're looking at pupils, what are we looking for? Obviously, reactivity, size, Equal, round, yep. My high school football coach, we assess his pupils today. He has one that's round and reactive, and the other one of them looks kind of like a hexagon. You got poking out a fork in the kid. So if we found him laying on the side of the road, we'd look at those pupils and go, head injury or something, right? We'd go, that's not right. That's normal for him. So, did you say football coach? Or football coach.
It's a good coach.
Mm-hmm. What else we have there? What's that? What do you mean by that?
How the patient presents himself to you.
Okay, so patient, so we had appearance, we'll count that. What on there?
I meant more like their behavior towards you.
Oh, their behavior? Okay, we'll put it with that. So EKG we have 3 and 12, right? 3 lead, 12 lead. But looking at that list, how many of those are ALS?
Probably not going to be engaged.
Well, we can put all that in there, I guess. Anything else? Capnography
Can be an advance.
can be, but I think we're teaching it at the EMT level. I know in like Whitman County, they're having LifePack 15s that have capnography, and I know when I go and do OTEP with them, and they're starting to learn about capnography a little bit. Not to the level that you guys know about it, but at least to know, like what I just said, low equals poor perfusion and that kind of thing.
And there's another skill on here you're missing. Temperature.
Temperature.
Temperature's got to be a big
Yeah.
one into your area. So,
Yeah. You know, and I'm glad you said that, Doug, because you know temperature is a big one. How many of us in our agencies have a great thermometer? Yeah, exactly. How many of us can take a core temperature?
Without putting a hole in it.
I have to teach a class in a month for my department on hypothermic cardiac arrest, and you need a core temperature. How do we get a core temperature in the field? Yeah.
so, and which reminds you again, if the rectal temperatures have all been tested and sanitized before they're used. So think about the poor guy that had to be tested on every single time.
Yeah.
You know, and the other thing though, if you guys are using a lot of ear thermometers, which I see a lot, the tympanic, know how to switch it to Fahrenheit. I get several times I have an EMT partner who switches it in. They tell me, well, it's Celsius degrees. Remember, you learn how to use your equipment so you know how to read Fahrenheit, or know what Celsius temperatures are very well. I don't know Celsius, so I always have to switch to Fahrenheit.
So we're going to do one thing with this, and this is a great little, another little assessment kind of refresher, is we also had all of our assessment questions, and then we called that our S primarily, right? So you get 3. 3 of those and 3 of those. So the same game we just did, but now you get to assess that patient a little bit. So we have a 70-year-old female with abdominal pain. So we want to know 3 pieces of her history. You only get to ask 3. Remember, I know in reality we'd ask more. And then you can do 3 vital signs, if you will.
So you get abdominal pain?
Abdominal pain. 70-year-old female. Let's make her a little older. 75 with abdominal pain. We'll just do a couple of these and then we'll move on.
Raise your hands. First person's ask questions. Which things do you want? This is the active participation.
Yeah. Got 3 things here. I'll nail something here. Okay, 3 good? He's got his 3 assessments, or his 3 questions. What 3 questions do you want? Ask medical, onset, and medications. Okay? Why do you want those three? Not saying they're wrong. Remember, I told you there's no wrong answers to this. And I absolutely mean that. There's zero wrong answers.
Well, I think pathological history can tell us.
Okay.
Onset. I guess depending on how you ask the question, you get out of that onset.
Okay.
Eat a big meal, or
All right.
go to the bathroom for days.
Sure. And then the third one was?
I guess just to clarify and see what George is doing.
Okay. So those are the, we'll use it as three. And what about, what did you want in terms of like vital signs?
So about the temperature, EKG, and then the appearance.
Temperature, EKG, and appearance. Okay, we're actually going to throw some numbers in. And you said again you wanted onset?
Yeah.
And this was, it's come on over the last 2 days, just normal daily routine, nothing out of the ordinary. And what was the other one? Past medical history, she's has GERD and is a diabetic. Her medications are Prilosec and metformin.
What is GERD?
What's that?
Those are still working for AMR. What is GERD?
Gastroesophageal reflux.
Heartburn. Yeah, roughly. We'll call it heartburn, yeah. So she's on Prilosec for the GERD, metformin for type 2 diabetes. And then you wanted temperature, 98. EKG is a sinus bradycardia, and appearance, she's a little cool and clammy. So based on that, I know this patient. So what's going on with this patient? What's that? Low blood sugar. So now let's give you a fourth one. You want to? What do you want to know now? What's the fourth one you want to know now based on his first three? You want to know blood sugar based off of the diabetic history? Let's say it's 200. Is 200 scary high? No, it's high, but it's not scary high. What's that? Her normal blood sugar. That's a good. That'd be a good follow. You know, the other questions you get to ask. That's a real good one. What do you normally run? I like that question. What's going on with this patient? This is a real. This might be a little early for this. This patient's an MI.
Sinus Brady. Yeah.
This is an MI, an inferior MI. Yeah. Now, the moral of this story is type 2 or elderly female diabetics have abnormal cardiac presentation. So that's what this one was. But so you based off your three questions, that generates another question, which generates another one. And that's why it's really good to try to get all these down, and you'll fill in all the pieces, and then you can start. If there's anything else, like you said, what do you normally run? That would go in that, I'd call that in that associated symptoms box, but that's other stuff we do want to know. That's a really good question with the diabetics. What do you normally run? So I run 200, right? Some do. Okay, let's we'll put that away. But that's a really good thing to do. So that's something you might want to come back to as the course goes on.
We will definitely be playing it. Dave's going to be back teaching with the course quite a bit. So you're going to see we're going to be adding this game probably to some future courses once you guys are in Module 3. And we'll give you those kind of aspects and see how quickly you can give it. And Dave will also give you some areas that you go to, right? Like you're responding to.
Oh, yeah. Yeah. Well, that helps.
Yes.
That helps, yeah.
When you know you're responding to the gardens or something like that, which you guys may not understand, but we'll give you some of those
Is that
clues.
AMR thing?
Is there flowers?
No, it's a valley thing.
So, okay, just to go with that, you're going to the adult family home or the true nursing home for an unresponsive. What is it? There you go. Just
Yeah.
off that. So, unresponsive.
What could it
nursing
potentially
home,
be?
Sepsis. Yeah, that's. Yeah.
You think about all the aspects. So you can see on this one, I'm going to give you this chair, Dave.
Okay.
So you can see on this lecture, there's 333 slides. Okay. So I want you to be going through a lot of these on your own. I'm going to pop through here. There's a video that's associated with it. There's lots of videos that are online you can do for patient medical assessment, and they're like 10-minute, 12-minute videos. This is where I want you to get really good at with things. And this right here is a huge aspect that we have problems with most students, and I get it from the standpoint when we're dealing with a mannequin, but we're also going to be utilizing you guys to be some of our mannequins and some of our actors during our assessments. This is the big aspect. You've got to get hands-on. You've got to give these assessments. And that's why we're going to go through all this fairly quickly, but I want to show you what an assessment looks like, and then we'll go through the slides. But you guys, I feel in my mind right now, you guys should be running all the calls and starting to run all the calls, even Delta calls. So if I'm an EMT and I'm in paramedic school and I'm running a Delta call on Dave, I'm going to come up and say, okay, what's going on today? Dave's going, I'm just having some chest pain. It started, a couple hours ago. Okay, perfect. I'm going to have my medic start to get a picture of your heart. He's going to get, some leads on, and he's going to get a 12-lead picture. Tell your medic to do the stuff. This is what you guys are going to do when you're out in the field, and we have our doing too. Okay, I'm also going to have my medic probably get an IV started on you too, but start asking those questions. If you ask all OP, QRST, and sample, you'll get a ton of information. Greatest question I love asking in my assessment is, okay, have you ever had this before? What are you going to get? Yes or no? Yes? Was this like last time? What are you going to get? Yes or no? If it was like last time, what did they do for you? Did that help? Perfect. There you go. You know exactly what you're going to do. No? Okay, I got to ask more questions. If this is the first time this is presenting, you got to ask more questions. But in asking questions, you also got to get some hands-on. So I want you guys to talk to your medics when you're working, or if you're in a BLS crew, take the lead. But I want you to start doing this. If it's a skill you cannot perform, ask your medic to start performing that skill. But you guys be the orchestrator. Start doing that. You get to tell your medic what to do. Hey, will you go ahead and give me a 12 lead and tell me what it looks like? But you can ask those questions. There's no reason. Now, if I start asking questions in EMTB and I'm kind of going off track, then my medic can bring me back on track, right? Or can ask questions that I don't know to ask. But that's where I want you guys to be jumping in and doing this sort. So realistically, I want you guys to be doing a lot of hands-on, checking them out, especially in our trauma patients. You guys went through trauma assessment. Today, when you guys go through trauma assessment, I want hands-on. I want a quick, down and dirty. I want to check, and I want you to check in your primary assessment. Circulation is what's going to kill you, right? So in my circulation set, after I check the pulse, I'm cutting off my trauma patients and naked patient. I'm assessing the abdomen, I'm checking the pelvis, and I'm checking the femurs. Okay? Why? Because those are the areas that's going to get the blood loss that's going to kill. So I want you to get the hands on. Then you can go back and do the secondary assessment. That's what I'm going to do on Dave here in a second. Percussion is a tool. What I want you to get from these is when you hit an area that you don't understand, I'm going to go over these. I want you to maybe understand the slide, because this could be coming up as a test question for Gary. These are fair game type things. I'm not saying they're going to be on there, because I told you math was going to be on there and it wasn't, right, Laban? So something like this, you might want to know certain graphs on there. Might just kind of go in there and understand what things are. I'm kind of going through this very quickly on here, so you can see what you're going to assess and how you're going to go. Just a quick review of these things. Again, this should be nothing new, right? All these things on here, this is BLS stuff, and this should be stuff you guys are doing every day. This is your bread and butter. So that's why I'm kind of going through this a little bit quick. Again, we're not going to go through this here, so I will guarantee you there's not a question on that yet. Maybe down the road, but yet. But getting these aspects. So when you're doing the assessment, I want you to kind of get an idea. Knowing these terms would be a good idea. You guys already had a question basically given a set of respirations. What is it, right? You had biots, you had Kussmaul's, you had Cheyne-Stokes or Shane-Stokes, or however you want to say it. Getting a good idea of what these are. This is how I would review this slide. Knowing this slide would be a good thing. It's more of where am I going to check pulse points at? Where can I feel and see things and get pulses at? That might be a good slide to know. But I would just want to basically here, and then I'm going to show you what I'm expecting on assessment. Getting vital signs, knowing what averages are, knowing what normal ranges are. So if you're given a particular scenario, you can know what you want to see or assess. Basically just being able to check a couple of things on here. I'm trying to just look in here. of specifics. Again, because there's so many slides, we're not going to go over this. This is a good slide to know with things, but this is going to be a third module. I can actually assess, and I've done this before, where I've assessed a patient's toenail, and I'm looking at her, and I'm like, you had an infection about 6 months ago, didn't you? You were hospitalized for something, weren't you? Picked it all out, because you can tell by lines, and there's different aspects. Clubbing, onycholysis, a lot of these different things up here will also tell you other things about what's going on, which you guys are going to go over in third module when we're really getting these things out. So these things right now, I'm not going to be quizzing you on now, but these signs really tell you a lot about what's going on. So we're going to hit this more once we hit third module, because there's a lot of disease related, but you got to know what the diseases are. Yeah. But you can tell a lot about patients by their fingernails and their toenails. Fingernails take about 6 months to grow out. Toenails take about a year to grow out. But they basically track progression of what's going on with your body in that too. So basically what I want you guys to be able to do is do a head-to-toe assessment. Now when we're doing an assessment on a patient, you're probably never going to get to the extent that it's doing here. But if you worked in a hospital setting, you worked in a doctor's office setting, you got to go all over the entire aspect. So Dave was my patient. I'm going to a head-to-toe. Hey, the first thing I'm going to do is I'm going to assess mental status. I'm going to ask him questions. I'm going to get his baseline. And how am I going to know his baseline if I'm in a house situation or on a call? Family, bystanders, is he acting as normal? So I'm going to assess the baseline from him. I'm going to be looking at him. I'm going to see how does he appear to me. Does he look pale? Does he look diaphoretic? It's that sick, not sick look that I'm looking into. Then as I'm going to come and assess to him, I'm going to check his head. And a lot of times I'm going to get hands-on. I'm going to feel, I'm going to look. I had a patient the other day who was all bandaged up and wrapped because of a bleed from the head. Well, I need to expose that as a medic. As soon as I expose it, it starts bleeding, and I had to wrap it back up again. But I need to know what's in there, so I'm going to pass that information on to the doc or wherever. Is it a laceration? Is it suturable? What's the blood like? Everything like that is coming in. How much is exposed? How deep it is? But I'm going to check out his whole head. I'm going to inspect everything. I'm going to go into his ears. We don't have an otoscope, so you guys aren't going to be looking in there, but some of these videos show in there. But I'm going to look in for his ears if he's complaining about ringing in the ears, buzzing, anything like that. I'll show you this video later in there where we've had someone complaining about buzzing in their ear, and you look inside there and there was a bug inside their ear that we pulled out. So it does happen depending on some of these places you're going. I'm going to check pupils. So I'm going to be looking into his pupils. I'm going to be looking for the reaction. I'm going to stop there. I'm going to check eyesight reaction. I'm going to have him say, look at my finger, follow my finger without moving. And I'm going to do an H pattern. What am I assessing when I'm doing that? What's that?
Reactivity.
Reactivity, muscle function, cranial nerves 4, 6, and 3. I'm also assessing on there. This is, I'm going to get you later. That's actually assessment that we do partially when we're doing posterior strokes. So I want to put that in the back of the brain. So I do have to do those assessments. I'm going to have him smile. I'm going to see there, there. What am I assessing? Part of fast exam for anterior stroke. I'm going to come on. I'm going to put hands on. Do you have tenderness when I'm helping on my hands are cold, so I apologize. I did right there. Do you have tenderness? I'm going to look across the front of the neck. I'm going to look, how do I see the thyroid cartilage? Is it prominent? What's that going to tell me? If I don't see a prominent thyroid cartilage, it's going to tell me that difficult airway. If I don't see a prominent on there, it's going to let me know I'm going to have a difficult airway when I'm going in. Because you might have a really fat neck, and those ones you should tend to be anterior, and I'm going to have more problems with that. I'm going to look if he has JVD. What if he does have JVD? What does that tell me? What's that? Could be intracranial pressure. Yep. What else? Right-sided heart failure. Blood is being backed up. Could be high blood pressure. Could be tension pneumo. Could be a lot of different things in there. So it's going to assess me. It's going to lead me towards signs, and it's an important one when I'm doing a lecture later on. I'm just going to check on his movement of the neck. Is there any tenderness? He's got lymph glands that go all the way down the back, across the front. There's one right here that can get very painful. Does he have infection going on? Are those swollen? And he's got neck tenderness. I'm going to check his neck rigidity. Can he bend his neck forward? Can he bend his neck forward? And when he does his legs pop up when he bends forward? Nuchal rigidity goes towards meningitis.
Okay.
So going to some other aspects that you guys are going to get into later. So there's a lot of things that I'm going to be assessing. I'm going to be checking out here. I'm going to check on his shoulders. Does he have pain here? Does his shoulder girdle intact? Did he deal with extremity injuries or there? I'm going to stick to the core coming down. So when I come down to the sternum, I'm going to actually press on his sternum. I'm going to see if the pain is actually related to his chest. Is it related to his heart? Is it related to his lungs? When we do CPR, do we break the ribs?
No.
No. Did I already tell you guys this?
Yeah.
Cartilage, right? So he can get costochondritis. So if I'm pressing here on the chest and that causes pain, and I'm pressing in here, he can have costochondritis. That's the cartilage that attaches the ribs to the sternum are infected. So I can assess that versus lungs. I'm going to listen to lung sounds. And when I listen to lung sounds, I'm here, 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 here. It's a pattern. I also do it to the back, here, here, and I go side to side, and I'm always listening side to side. I want to listen to the difference from apices to bases. What if I don't have any lung sounds in the bases, but I have it in the apices? Well, depending on what things, it could be a pneumonia, could be partial collapsed lung, could be a hemothorax, could be a lot of different things, but you guys got to be able to assess that. Again, I want you to listen to lung sounds on every single patient. They got a stubbed toe, listen to their lung sounds. The more you listen to normal, the more you're going to listen to abnormal. I had a patient on there, I listened to this side, I hear normal lung sounds, it sounds like. I go to this side, and it sounds like when he's breathing, you're just, and the other side is seeing normal. He has hyperresonance in his lung, which means his lung was so tight. Blow up a balloon to a certain level and tap on it. Now blow it to its max level before it blows up and tap on it again. There's a hyperresonant sounds on there. Again, you couldn't tell exactly there, but you knew something was abnormal. He had one lung blown up so bad, we decompressed him, all of a sudden he breathed just fine again. So he had hyperresonance in there. So tension pneumothorax present lots of different ways. So I wanted you to listen to normal, so you may not know exactly what it is, but you know it's abnormal. So you're going to listen that way. The other way you can tell with that is if you have someone holding up, it's called percussion I just talked to you guys about. Percussion basically is when I'm going to come in here and I'm going to tap on my knuckle, and I'm going to go for sounds. And I'll go on the rib, and I'll go below the rib. Usually what I'll do that is I'll have someone listening to here, and if they hear that sound bounding through that, that gives me another idea that he's got a hyperresonant sounds that's coming in. The places I'm going to do that, again, I only usually did this as I haven't had to do it as a medic yet, more in there, but you'll do it in other areas. In the stomach, when you're going to come on, you're going to percuss in the stomach, and you're going to see if there's sounds that come bouncing through here for bowel sounds. It's a tool on there you guys will probably never use, but I want you to be aware of it and what you can do it. There are certain situations that you will. So I'm going to assess his lungs. I'm going to compress on the side from his chest as well as where I'm compressing here. And I'm always compressing like this, and I'm pressing here. Why? Because I'm dealing with females too, right? I could care less. It's nothing sexual. It's nothing of that nature, but I've got to be professional with it. So I'm doing here. When I'm doing 12 plates, I'm lifting and I'm pressing in here. Know how to assess anybody. You should be able to do it. We do it on the students, and we're going to be doing it on males and females here. I want you guys to be able to do it. I always use the term, and I'm sure Dave has his own way, but I'm going to let him know. I'm going to get up close and personal with you. I'm sorry, I got to do this. And I explain and I show them what I'm going to do on me, and then I do it on them. But get in the habit, and I want you guys to be on and touching and finding these out. When you get into the abdomen, what do? We do this, right? I can't assess anything, right? Get in there and get deep. So when I press on the abdomen, I'm pressing it deep. It should be some pain that's associated with that, because I've got to get inside there and I got to feel. So don't be afraid to push in there and do it on each other. I want you to understand what it feels like so that you know what you're doing on those patients. But you've got to get in there and get those assessments. You've got to go and find out, is there rebound tenderness here? Is there rebound tenderness in other areas? What am I assessing when I press here? What do I assess when I feel an organ right across here? I already told you one that, guys, right? That liver edge is coming down. And they've got hepatomegaly, which means that they could have heart issues and a heart enlargement. Some other aspects that are going on. Know what's in each of those regions. But to do that, you got to press. Can I assess an abdomen and AAA if I just do this? No. Now, granted, a pulsating mass is only going to happen about 15% of AAAs. Very minimal that you're ever going to feel a pulsating mass. But if you're going to feel it, you got to get in deep. You got to find this out. So I want you to get a touching. When you get to the pelvis, again, the pelvis is the place that's going to.
The book on that said you could use your stethoscope and hear turbulence on that. Would you be able to? On a
Depends. The most, and I've seen 3 AAA patients, confirmed AAAs. All 3 of them had beer guts. I couldn't push hardly anything down there, and we diagnosed it another way. So I physically have never heard it.
No, I've had one. He had
previous AAA, so he already had a bunch of deformity down there from where they cut him open.
So if you're listing specifically on there, I could see it because it's a rush off. I've never physically heard it, so.
We might see more AAAs, but they come in as cardiac arrest. So we don't know that, you know, and we treat them as presumed heart disease. We don't get those people back. So one that I know of that was live for a while. Yeah, he had a previous one. We assess it other ways. It's blood pressure on top, different arm. Yeah.
History, I'll tell you about mine later on, of how I got my 3, and they didn't present like a AAA at all. How you normally would see. Pelvis, again, an area that's going to kill them. So when I'm assessing pelvis, people always ask, how do you assess the pelvis first? Do you press on the outside first, or do you press on the top first? What do you guys think? It actually does matter from the sounds. Okay, and here's the reason is because am I assessing a pelvic fracture or am I assessing a hip fracture? And again, a hip fracture is a what? Femoral neck fracture, right? So it does make a difference to assess. So what's going to kill me? Is a femur fracture going to, femoral neck, hip fracture going to kill me? How much blood loss am I going to get from a hip fracture? 100 cc's. That's it. It's contained in that area. That's what they lose. Unless you had major trauma, which also ripped it out, but then you're getting something else. How much blood loss with the pelvis? Lot. Up to 3. 2 is a good average number. So what I'm going to do is I'm going to start on here and I'm going to press. I'm going to get right here in the pubis symphysis and I'm going to press. And I should be able to, if my patient's laying flat, I should be able to put most of my body weight down. If I put a little bit, 10, 20 pounds of pressure and it starts to open, I know I got an issue. If it doesn't, I'm going to put a little bit more and I'm going to see on there. I can take Dave sitting on the ground, I can put all my weight on it. Just go right up on my arms. It'll be uncomfortable, but it won't hurt. It'll be stable, right? Assess that. Now go to the sides. Because if I press on the sides and I get pain, then I know, okay, which side am I dealing with? Especially if I'm seeing short down there. But I got to see if the pelvis is involved, so I go pelvis first, then I'll assess that. When I'm going down the legs, I'm feeling down the legs. I'm going to use a lot of my area on history to assess and I identify if he's got a femoral fracture based on mechanism of injury and that. But I've got to get in there and get hands-on. And I'll tell you, I've been wrong a couple of times where I've gone in and felt that, and I can't feel crepitus, but I'm like, okay, based on the mechanism, this has got to be fractured, so I treat it as fractured. And sure enough, it's fractured, but I never felt crepitus. And crepitus is that bone motion. Legs, femurs are harder area. Arms a little bit easier. Femur, big muscles on there. It can hold that muscle, that bone pretty stable where it doesn't move. But I'm assessing this, and I'm also cutting off this clothing too to see, is there any bleeding associated with an open? Because what do we consider to be an open fracture?
Bone sticking out.
That's the most common thing, right? When people go through an assessment and I say, do you have a femur fracture? Well, it's later in here. They think the bone is open. Okay. If you see any opening or cut in the skin, technically that can be an open fracture. I had a forklift fall on my leg. My bone snapped out both sides. I have a small hole right here. It's about this big. You can still see the scar. Bone came back into my leg. They didn't treat it as an open. Got an infection into there that they later wouldn't go in, and now I've got a scar right here to here that's about this wide because they had to leave it open for a week. And they pulled stuff out because they didn't give me antibiotics and didn't treat it as an open infection. They didn't know. They didn't assess that. So those are different things you guys have to see. So any opening or bleeding around there, just because there's not bone scooping out, that's still an open fracture. And I'd rather you tell them, I think it's open, and have them check and find out that it wasn't, that it was something else that poked them, than you not tell them, and then that person gets an infection and they have to go through the stuff I had to go through. So do that assessment. Get that hands-on. Feel for there. When you're dealing with a knee, I can show you guys later for sports-type injury, but it's probably something you guys aren't necessarily going to do, because if they've got knee pain, what do I want you guys to do? Stabilize it. Just stabilize it. I'm going to go and I'm going to do an anterior drawer test. I'm going to check anterior. I'm going to check my PCL. I'm going to check my medial meniscus. I'm going to do a twist. I'll do something. If I'm really doing a knee, I'll put him on his stomach, and I'll twist his knee in. I can turn sides, and I can tell exactly what's wrong with his knee specifically, but that's my background. I'm not expecting you guys to do that. I can check down the leg, and I'm going to see if that's intact. I'm going to check for pulses. Now, where am I checking for pulses on the foot? Dorsalis pedis and posterior tibialis. Go for the posterior tibialis. The dorsalis pedis is the hardest one to find. So on top of the foot, you'll find most people, if they do take it, especially nurses in the hospital, they'll put an X on it so they know right where to go back to. It's hard to find. Posterior tibialis, check this on yourself, check it on friends, check it on your spouses, kids, whatever. It's right inside. You'll find the medial malleolus, which is the bone inside, which is where we do the IOs, correct? Just above there. Find that, slip right behind it. That's where you'll feel a pulse. Very easy. Easy spot to get to. I don't even take people's shoes off in most cases. I go right down there. That's where I assess my pulse. Really easy to get to. Take the shoe off if you need to take the shoe off. Assess the foot. If I don't need to take the shoe off, I don't take the shoe off. If the foot's not involved, I'll leave it on. I'm not too worried about that. But make sure you're getting a good hands-on. Come into the arm, same thing. Get a good hands-on, feeling on here. Check it in there. Is there any potential sign of crepitus? And if there's a mechanism that makes me think that that could be broken, it's broken until further notice, right? Treat it as such. I'd rather you over-treat something than under-treat it. Checking grip strength, checking push-pulls on the feet. All those are going to be big aspects of getting to go. But you guys have got to be doing this. And certain things are going to lead you to other aspects. You'll find out he has pain when he does this motion. His pain when you press here. Those are going to lead you to other things, but you got to ask those questions. I talked to you about bending the neck and what that's coming through. You didn't know what nuchal rigidity was yet? Nope. Okay, no, that's fine. I don't expect you guys to know that yet. We're going to teach you that. But again, you may ask questions and get some things there that you don't understand, that when you pass on to the doc, hook something right into them, and it takes them right down to where they are. Same thing as an EMT, you may ask a question that your medic gets on scene, and as soon as you say a certain thing, they know exactly what it is, and you may not know. So you got to ask all the questions, do a good assessment, because something you may not know how to treat, someone else is going to know. So make sure you're passing it on. So I want to make sure we're going through that area. When I am assessing his face again, head to toe, there's a lot of things in the slide that talks about opening his mouth, looking inside his mouth, looking for different things. There's the tongue. There's actually, I'm thinking there's a question eventually on here that talks about oral thrush. So exposing the tongue, having them stick it out. Look in there. If it's covered in this white material and stuff, that's called an oral thrush. What is oral thrush? Does anyone know? It's a yeast infection, but it can also become because of a lot of different things. So what's the #1 reason people have yeast infection or candidiasis? Steroids is 1. 2. HIV. Anyone who's depressed immune systems, they'll get that. They'll get fingernails over, so it can tell you some other things about their history. There can be other aspects too that can cause it, but a depressed immune system, they can't fight off a fungal infection. First place you'll see it on the tongue. Second place you'll see it is thick fingernails, discolored yellow. You'll see it on toenails as well. So these fungal infections come in really there, but I want you to be aware of that in case you see something on the tongue. It's called oral thrush candidiasis. It's a fungal infection, in case that comes up. So when you're going through these slides are going to be in more detail. And like I said, go to YouTube. I love YouTube. They have some really detailed physical things. They do stuff from aspect of doing checking for with a little needle-type thread and coming in, do they feel that sensation? How does that feel? Doing brush sensation, doing a full neuro exam. I'm not expecting you guys to know that. But I want you to be able to test on here. I want you to eventually, we're going to get into neuro, so I'm going to start progressing that way to where you guys all know the dermatomes. You guys know what dermatomes are? Who doesn't know what dermatomes are? Okay. So dermatomes are basically, it's a geographical map of the body that's released on your spinal nerves. So the dermatome that comes right across here, who knows dermatomes? T4. T10 is the umbilicus. So that basically means from my thoracic vertebra, my spinal nerves that come out fill this area. From T10 fills this area. When I've got my leg, I've got L1, L2, L3, L4, L5, S1, S2. So if Gary didn't tell you he's going in for some surgery, what's he going into surgery for? Back surgery because he's got an impression on some nerves. Well, if you ask him where his pain is, it follows the dermatome from where the compression is on his back. So you can find out different things like that. When you get neck fractures, cervical fractures, different levels show where you get shut off and where you're coming down, so that stops the respiration and other aspects. So dermatomes are important, especially on nerve when people are having pain on one side or different areas. It's like, where's that coming from? Especially if there was associated back injury. You can tell exactly where the level of the injury was. So you got to be able to assess and know those tools. A lot of tools you guys may not know yet, but we're going to get into, to where you can feel on any part of the body. You should know, if I say you got an injury at this spot and it's affecting this area and it's very painful, what vertebra does that go back to? You guys will know this. Right now I'm not expecting you to know it, but I want you guys to be able to know this and the assessment. And if you won't get that assessment unless you get a hands-on and see that, and unless you ask the right questions. So it's not only asking good questions, but it's getting a hands-on and touching everything. Going down the back. And what am I looking for when we check the back? We always say I'm assessing the back. Yeah, I'm checking the spinous processes, right? I'm feeling down the spinous processes. And do I feel them? Do I feel intact? Am I getting any tenderness when I go down that aspect of the back? Do I feel any area when I'm coming down the back that feels crushed or all of a sudden it drops off? Is there all of a sudden, oh, I hit here, oh, it's complaining of pain and he moves. And I feel motion down there that could be a fracture associated with it. You guys won't know this unless you get hands-on. My other thing is, too, especially more so with kids, but I deal with every patient, if Dave's complaining of an arm injury, I'm going to start my assessment of how it happened. Let's say he fell and he hurt his arm. Anywhere else hurt? No. Okay, well, I'm going to assess his head, his neck, his back. I'm going to assess his leg. I'm going to assess other areas. Last part I'm going to assess is the arm. Because I know if I touch the arm, it's going to hurt, right? Where he said it hurts, right? Do I need to assess it? I do need to assess it to an extent to understand that. If he said it's just specifically isolated arm injury, I'm going to check it. I'm going to feel. I don't have to move it too much. I can assume it's fractured and just put it up and wait till X-ray. But you've got to get hands-on and you've got to assess the other areas. So I want you guys, starting with the trauma assessment today, I want to see a full assessment on there. To where you have a partner say, okay, take C-spine based on the indication or not. You know, if it's not indicated, don't do it, but indicated C-spine. Check his airway. Open his airway. Is it open? Is there anything lodged in there? Is he breathing? Circulation. Circulation is a couple things. Where's his pulse? If I have a pulse on the wrist, what's his BP? At least 80. It's above 80. Here? 60. 60. 60 for carotid. And you can also tell from the sensation on it. Now I'm going to go, okay, now I've got ABCs in the circulation. When I get hands-on, I'm checking his color. I'm checking his temperature, his sensation, how is he perfusing. I don't need a pulse ox in most cases, and I'm sure Dave feels the same way. I can assess someone's, how they're satting by their look, not just with pulse ox. I'll want to get it and see where it's at, but I have multiple times our pulse ox doesn't even work sometimes, so I can assess it other ways. Then what I'm going to do is I'm going to cut as close as a trauma situation, and I'm going to start looking for things that are going to kill him. Did he fall off his roof? Okay. Well, after I check circulation here and he's got a pulse and it's fast, I'm going to cut down his pant legs, I'm going to cut up his back, I'm going to look for other injuries, and then I'm going to come through and I'm going to start pushing on his belly. What is that going to tell me right off the bat? I got there 5 minutes after he fell off the roof. Yeah, but I'm going to press it, maybe it's soft. Okay? Make sure you go back and check that as part of your vial 5 minutes. And maybe 5 minutes later, now it's rigid, and he has slow bleed. So I got to check it, but not only do I reassess my vitals every 5 minutes, I reassess my assessment, because that's the area that's going to kill him. So don't just check the abdomen and go, oh, it's soft. Okay, I rechecked his vitals. Well, his pressure keeps going down, and everything else here. Did you recheck his abdomen? No. Go back and recheck his abdomen. Now he's rigid. Gives you an idea of where it is, but you got to get those baseline assessments, and those are the things I want you guys to do. But if you don't get those hands-on, and you don't check them out, you don't know where he's going to go from that. And we got to see where he's trending, right? We got to get those multiple aspects. But if you don't press and get those things, you're not going to understand and see. And I'll give you an example, too. So I had a gentleman on the ice last year. He said he was walking. He went to turn. His legs stayed still, and he felt a pop, and he went to the ground. So I'm assessing the patient. I'm knowing he's probably got a fractured femur. I'm thinking, okay, he'll probably give him a little pain medication. He's doing okay. My EMT says, do you want to cut off the pant leg? I'm thinking, so this is the trap that always get me. I'm thinking, no, I don't need to look at it. It's probably broken. We'll just get set. I'm like, yeah, cut it off. His leg looks like someone was twisting it. No one was touching his leg, and his leg was twisted. he basically got a spiral fracture and that skin was twisted. I'm like, oh, yes, he needs a lot of pain medication really quick. Didn't change things what I'm going to do, but it basically changed my perspective of how much pain medication does this guy need or not need when I see the twisting. So you've got to expose this. You've got to understand how stupid would I look if I wouldn't have cut his pant leg off and drove him to the hospital and they cut him off and they're like, you know about this?
Oh, yeah.
I've looked dumb before. I don't like looking dumb. So I've also found, too, if my EMT ever asks me for something, I always say yes. Because the second they say, do you need temperature? No, they're fine. He's going to be septic. He's going to have a high temperature. You want a 12-lead? No, they're fine. He's going to have a full-blown MI tombstone. Something like that. So if they ever ask me, if anyone ever asks me for something, I'm like, yeah, do it. Because if they do it, then it's not going to be in my patient's going to be better. That's my role. That's where I'm doing. So, but do those assessments. Get hands-on. Start doing those things. Get exposures on there. And that's, I'll tell you, that's the thing we fail at the most in this class. Not your class specifically, but in here. What we get from all the instructors is everyone's afraid to get hands-on. Our assessments have been poor every year, and we're trying to find different ways to change that. And your class is hopefully the class that changes it, where you guys are getting on hands-on. So I saw you guys were in with Maurice yesterday. You guys did a lot of talking, right? Talking about things on there. So today there's no talking. Today it's basically Phil's going to be your guy. He's going to give you an assessment. You guys are going to just get right on and start doing hands-on. And this should be 10 minutes. I should have my trauma assessment done in a minute or 2 minutes.
Yeah. The whole thing should be 10 minutes.
Yeah, the whole assessment should be 10 minutes. All your questions, your package up and done. In fact, my EMTs, when we're doing finals, they're getting done in 7 minutes. So, just saying.
Thanks, Doug.
Yeah, just a little pressure. So, anyway, so that's kind of what I want to see from there. So, again, there was a lot of different things on here. Scalp pneumonic. You guys all know scalp, right? Don't memorize scalp.
Oh. That's right.
You just remember to know your 5 Ds. 5 Ds of dodgeball. Duck, dodge, dip, dive, and dodge. So, that one will be on the test.
The 5 Ds.
The 5 Ds, yeah. Well, actually, there's 8 Ds of stroke, and that's where I always use my joke there. You don't need to know the 8 Ds of stroke. You need to know the 5 Ds of dodgeball. So you can see on this here, this is just going to give you a more aspect of doing these assessments and pushing it here. What are they assessing when they're doing this? They're doing 2 things. They're checking facial bones for fractures because there's lots of fractures across the area. And there's different criteria when we get fractures of the face and affects the bones across in here and whether it goes up the nose, and we get floating fractures. But we're checking that for any bones. But there's lymph glands that go up there. We're checking sensation. There's a lot of different things we're inspecting for. When we're checking the back of the neck, we're seeing if there's any rotation, if there's any pain in the TMJ, temporomandibular joint. We're seeing, can they open the jaw? Is there any restraint? And then when I'm coming down, I'm checking for inflammation and nodules when I come through here and in here. Because if I see inflamed nodules, that's going to lead me to a lot of different things. Again, checking the eyes. Here's the exams. We're not going to do any of these type of exams, but you might be looking into the sclera. The sclera, when I get into mine, we're going to talk about different colorations in there, whether we see red, whether we see yellow, whether we see a lot of different things. It can tell us a lot. Is it clear? We're going to do checking for pupils and how we respond. Not going to do that, but we're going to do this H pattern, which again is going to check our cranial nerves as well as a couple other things too. We're not going to go into the otoscope or looking, but specifically looking into the ear a little bit. I'm going to show you guys a slide when I do my lecture on another one where there is actually a bug in the ear, and these have been found. And the guy complained about a bug for a long time, went into the GP, and he pops and looks and goes, holy crap, pulled out a bug. I've seen spiders crawl out of people's ears. I'm not kidding. Yeah. Checking for nose. We want to check positional areas. We're looking for straightening. We're looking for nose fractures. So I just kind of want to be looking for a couple of things in here. But you'll see in here, this is all about assessment. When you're looking in the mouth, they're looking for a lot of different things. Ability to move tongue. They stick their tongue out and they move it side to side. What am I testing? Cranial nerve 12, right? So different aspect. When I'm looking in here, I'm looking for, do I see swollen glands? Do I see tonsils and adenoids swollen? Is this going to be a difficult airway if it comes into? Do I see soot in the mouth with the patient we had the other day who had kerosene thrown in the fire and it was smoked up all in her face? Do you see black or anything inside the mouth, which goes, I need to intubate that patient. So you need to assess those things. Have people open up their mouth, check their voice as they're going. If I see any type of soot or black or discoloration or anything like that, I better be thinking about, I need to take this patient's airway sooner or later, because otherwise it's going to be swollen and I don't have those opportunities. So all these things are going to be as far as the assessment that I want you guys to be understanding and doing. So refer back to these, again, as you will from going through here, but do the assessment like I showed you. That's where I want those hands-on. I want them coming into this. And you probably won't do all those assessments in every single patient, right? But that's why we call it secondary exam. So when I do my primary exam, if I find out that I've got chest pain, where am I going to do my secondary? All those things I told you about. We're going to do the palpation, the percussion, everything from there. If he has a knee issue, where's my area go? My secondary assessment's all going to be on the hip, the leg, the femur, going down the kneecap, going down the leg, and I'm going to assess those type of things. So all these things are very important. You're not going to do it on every single patient, but you are going to be doing it on these patients to find out what's going on, and you're going to use those specific areas for following up. Questions? You guys got it?
A little wrap up on that, and Doug said get out there and do the assessments. If you're not able to, well, then be very critical of the person who is doing the assessment and see, are they going hands-on? When you guys show up with us, and you walk in, is everyone just standing at their arms crossed talking to the patient, or is someone actually assessing the patient? And if the answer is no, then when you get in the back and do whatever it is you do before you drive off the way, there's your chance. You can do some assessment there. But I think that's something that I can only speak for the little bubble I work in our county, but we're not great about being hands-on with people. We look at the numbers. Oh, the pulse is 100, respiratory rate's 36, capnography's 20, and they've got a history of UTI. Okay, they're septic. By the numbers they are, that's usually where it stays. They touch the patient, put the IV in, and that's it. So yeah, and that's something that we all can be better at. And I'm throwing myself in there and saying, when I say all of us, me too. So, yep. Done?
Questions? Good. Give it a hand.
So I'm going to stop you right here, Gary.
Yep.
Is the scalp pneumonic going to be on the test?
It all depends. Only for Jeff Pipe. The rest of you don't say. Okay. Back at 12:30.